what I would like to talk to you is what is the cardiologist of tomorrow. And this will also be a president's page in the European Heart Journal shortly. So there are turning points in history, and this is one in 1997 when the then chess champion Garry Kasparov lost against Deep Blue. So this was the first time that a computer program was able to beat a chess champion in a rematch on the tournament conditions. And this is impressive because chess is not just a mathematical game that a computer program can easily learn. It's a strategic game. So now in this situation, I turn to my favorite philosopher, Elon Musk, who actually said that studying medicine and going to medical school is becoming pointless due to the rapid advancement of artificial intelligence and robotics. And the question is he right? Yeah, what happened over time and where do we stand now? So this is, when the invention of the first stone tool came up, force was crucial. It was what made you a leader. And then with the invention of the steam engine by James Watt and others in the late 18th century, physical work became less and less important. And today it is completely useless. You can, sit in front of your computer and change the world, or sit in the White House and do the same. And you don't need any force. You should actually need some intellectual work and capacity. But the question is this also going downhill over time with the artificial intelligence? The question is, what is the GP doing in this context? An imager, a radiologist, or an interventionalist that uses his hands? And the next one is, of course, the robots. You can see lightning on the run. This is the half marathon in Beijing this year, and this is who won. It was lightning winning, 50 minutes and 26 seconds, 7 minutes faster than any human being before him. And at the same time, there was another robot that looks a bit less human, but he plays ping pong really well and beat several champions. So the question is, how are we doing in this regard? We are, of course, the crown of evolution. We have 8 billion neurons, 100 trillion synaptic connections, some a bit more, some a bit less. The crown of evolution. The question is, can a computer match that? And can a computer surpass that? Now the question is, how can we apply this into cardiology or cardiovascular medicine? First of all, we have genetics. We have clinical data, we have biomarkers, a laboratory, ECG, and imaging. We put everything together in a basket called computer, where we enter data and we train and derive a first cohort. Then we put it in a black box with algorithms that only few of us understand, and we come up with a first algorithm. But this is not enough. As we say in the UK, we have to test this across the channel in Europe, for instance, and have a verification cohort. And then we go back to the black box, use all these logistic regression support, vector machine, random forest, XGBoost, whatever. And then we come up with a final confirmed algorithm that is ready for use in clinical practice. Okay, then, of course, how can we use this when we see patients? All right, first thing, patient is waiting for a doctor, which is very common. Of course, not in my case at all, but it is common. First encounter with the doctor, you look at his face and you hear his voice. And then, of course, you examine the patient. Then, of course, you send him maybe to an ECG, to an echo, or to a CT scan. And for all of that, AI will be essential. So for instance, patient is waiting in the waiting room. And then, of course, the avatar says, this is the Articulate Medical Intelligence Explorer trained for taking patient history. How are you today? And the patient says, oh, well, a little bit of chest pain and shortness of breath when I walk up the stairs. And then the question is how good it is. So they randomized it to general practitioners and the algorithm, the avatar. And here are for different items, you can see the GPs in blue and the AMI in red. And for all of it, the Artificial Intelligence Explorer was better. And then, of course, you hear the voice. And now there are algorithms that hear from your voice arrhythmias, whether you have atrial fibrillation and whether you're congested, because we're not just congested in the lung, we are congested in the vocal cords as well. And this is fantastically predictive. This is a vocal biomarker. You see in the left mortality quartiles, the more congested, the worse, and the more congested, the more you are hospitalized for heart failure, as shown on the right panel. And then, of course, the question is, how do I make a diagnosis? And you know, in the old days, you actually, first of all, I have to focus on the ECG, I'm afraid. The ECG is, of course, where we are kings, the cardiologists, we think, but we're not. And here is a trial with more than 10,000 patients from Taiwan. They randomized patients to a doctor with an AI-enhanced ECG or normal ECG, normal usual care. And then they looked what happened when they present as an emergency case in the emergency room. And you can see in panel A on the overall there was no significant difference. But in those assessed as high risk by the physicians, there was a 30% reduction in mortality by the doctor that had an AI-enhanced ECG. And of course, then comes imaging. You send him to the echo. And in the echo lab, of course, you have an algorithm looking at the left ventricular systolic and diastolic function, EE prime, aortic valve flow, and stenosis. And eventually, the image processing will lead you to a diagnosis, maybe even recommendations on how to handle the patient. And then you send some of them to the CT scan, particularly when you're not sure about it. And this is work from Oxford by Charis Antoniadis. And basically it shows that this plaque that you see here, coronary plaque in this schematic, has a lot of white blood cells in there and produces cytokines. These are released, of course, into the bloodstream, and that's what we measure. But at the same time, it's also released towards the perivascular fat, and that is called the fat attenuation index because the inflammation changes the structure and biology of this tissue. And the question is how good it is, and you can see here it is fantastically predictive for cardiovascular events. These are MACE quartiles in the overall population on the very left, in the middle, in those with non-obstructive coronary lesions, so plaques that are not obstructive. But even there, if you have an inflamed plaque, it's bad news, as you can see in the red lines. And then on the very right, these are the ones with obstructive coronary disease, so that the scales are different, but basically independent of obstruction, non-obstruction, this is predictive, is really impressive. And so when you have done all of that, the question is, what the hell does the patient have? You know, and not always are we sure about it. In the old days, you asked the white-haired professor because he knew everything. But today, the youngsters, they ask ChatGPT-4. And how good is it? Well, this is a paper in New England AI, and you can see here the Gaussian distribution of doctors. On the very left, you see those that urgently need to repeat their board exam, and on the very right, the fantastic white-haired professors. And here is when they, the bad ones go to repeat their board exam, and they don't know what the hell to say. That's guessing, and this is where GPT-4 was. So they're really fantastically good. And then at King's with Kevin O'Gallagher, we looked at whether we are able to make a diagnosis of HFpEF. And we took the Chope and Piske criteria published in the European Heart Journal that in the red line you see actually has the lowest survival probability. And we looked how many of our consultants made the diagnosis. And here it is, 8.3%. It was a bit higher among cardiologists, but overall not so good. So in the future, we will have an electronic health record. And in this the health record, there will be a co-pilot. And basically, it will pop up and say, "Dear colleague, this is your co-pilot. Did you consider HFpEF?" Because he puts everything together. The criteria would be met. We would suggest sodium glucose transport inhibitor, and you say, "Damned, I missed it, but thanks to my co-pilot, I'm a good doctor." And then, of course, we at the ESC were conscious of that, and we put all the 20 valid guidelines in one box using large language models, and we call it the ESC chat. And there you ask a question, you get an answer, and we work on it. We will also produce this for the TikTok generation, where we, in the future, will also have an avatar that you really see, Kevin or Emily, as you will see later. And then, of course, the question is how to predict the outcome. In the old days, we went to Delphi, and in a smoke-filled room, a lady knew exactly what the future will hold. But today, of course, we ask the algorithm. This is just one example that we did with Florian Wenzel, published in The Lancet recently. And you can see these are patients with cancer that have a myocardial infarction and those without cancer. And you can see that the predictive value of different parameters are completely different if you have cancer compared to have no cancer. This is also true for ischemic events, and then, of course, for bleeding a bit less. But basically, we can construct a score. This is called the OncoACS score that's now available on the net. And then, of course, we also need to make sure that people take actually what we preach in the guidelines and what they actually see when they use the EC chat. And we found in the Imperial College registry on the left for all-cause deaths that if you don't measure your LDL, the upper line, you have a high mortality at 7 years. If you measure it once or twice or more, it goes down. So the better you look for the LDL control after an infarction, the better your outcome. And of course, if you reduce or stop the statin, there's a huge increase in mortality. So we decided to develop an app for patients, an app that talks to the patient, has interactive features, documents the steps to say what to do in terms of lifestyle, ask your doctor, know your numbers, and we're working on this now with a company as we got funding with the ESC team. And then, of course, with Diana Gorok, we also looked how good is actually a virtual assistant to improve clinical practice. And this is what we did with 100 patients randomized to usual care or to a doctor, a heart failure doctor that had a virtual AI assistant at hand. And then we checked on whether the implementation of the fantastic 4 drugs for heart failure are actually better implemented. And you could see that indeed the virtual assistant helped to implement drugs better. BNP was lower, ejection fraction was better, and so forth. And so when we look at algorithms, we have to make sure they're good quality. So we published this with Volker Asselberg and Florian van Rijn, and you can see it should have a clear intended use. It should have a verification cohort across the channel. Then, of course, large numbers in the 10 to 100,000s, openness of data software, and then of continuous upgrading if required. And then, of course, we learned this from airline industry that I just used to come here, that with a co-pilot, it makes you faster, more precise, and safer for the patient. And so what is the cardiologist of tomorrow? I asked Laura because I wasn't sure, and here is her response.
In the age of AI, the role of the cardiologist is not disappearing. It's evolving. To succeed, cardiologists must combine traditional clinical expertise with new digital capabilities. First, core clinical skills remain the foundation. AI can analyze images or ECGs, but it cannot replace a cardiologist's judgment. especially when data are conflicting or ambiguous. Understanding cardiac physiology, choosing the right tests, and making nuanced decisions are still essential. Second, cardiologists need AI literacy. They don't need to code, but they must understand how algorithms work, what data they're trained on, where they may be biased, and when their output may be unreliable. The goal is not to trust AI blindly, but to use it critically and safely. Third, the modern cardiologist must be comfortable with digital data. Wearables, remote monitoring, and AI-enhanced imaging produce massive amounts of information. Cardiologists need the skills to interpret this data and integrate it into clinical decisions. Fourth, ethical and privacy awareness become increasingly important. Cardiologists must ensure patient data is protected, understand the limitations of AI, and communicate transparently about how these tools influence care. Fifth, AI will reshape workflows. Cardiologists should be able to work with informatics teams, understand how AI fits into electronic records, and help redesign processes to make care faster and more efficient. Finally, human skills matter more than ever. As technology becomes more complex, patients still need empathy, clear explanations, and reassurance from their doctor, not from a machine. In summary, the cardiologist of the AI era combines clinical mastery, digital and AI literacy, ethical judgment, system-level thinking, and strong communication. AI will not replace cardiologists, but cardiologists who use AI will replace those who don't.
So clearly, that's the summary. We can now use clinical data, biomarkers, imaging, gadgets from watches and so forth. Then, of course, genetics, and we should come up with a digital twin that allows us to really provide personal medicine that was a promise so far, but tends to become reality with the integration of everything that makes us faster, more consistent, more integrative, and more precise for the patient. And I thank you for your attention.